All right then, well, welcome back everyone. It is another week of Joint School, and well, it's been a week where there's more signs of spring, schools are reopening, and dare I say it, there's a bit of hope in the air. And so today we'll be digging into the somewhat daunting topic of risks and complications in relation to knee replacement. And with me today to captain us through this session is Miss Chloe Scott, a hip and knee surgeon at the Royal Infirmary in Edinburgh.
Hi Axel, thank you very much for having me.
Thank you so very much for joining us. It's an honor and a pleasure. Is there anything else you would like to say sort of about your role and day-to-day activities before we hop into the session?
Not really. So I'm a hip and knee consultant in Edinburgh, so I predominantly do knee replacements and hip replacements, but I do quite a bit of research as well, specifically on knee outcomes. So that's my background.
Okay, well, thank you so much for sharing your expertise with us. Now, of course, as with all of these sessions, you know, these conversations are meant to sit alongside and complement the conversations that you out there will be having with your surgeon and other members of your healthcare team. So it doesn't replace any other medical advice, but hopefully we'll be able to elaborate and expand on some of the key points and just kind of cover some of the things that I'm sure you watching this will be covering with your surgeon as well. But you know, in this context, we just have a bit of a different sense of goalposts, a different sense of time, and we can kind of break things down and approach things in perhaps slightly more leisurely manner than what might be available in your average clinic, perhaps. And in any case, just hopefully a nice complement to sit alongside that conversation. And so before we start sort of going through the list of the common risks and the complications to be aware of, perhaps it's worth sort of beginning with, you know, highlighting that a knee replacement, total knee replacement, is a common procedure and is quite successful.
Absolutely. So knee arthritis is a very common condition, and it's important, I suppose, to start off by realizing that just because you've got arthritis in your knee doesn't mean that you're going to end up with a knee replacement. It's actually a fairly small proportion, about a quarter of people who actually end up ever needing a knee replacement. So just because you've had that diagnosis doesn't mean that it's an inevitability. So knee replacement surgery it's really an excellent operation for getting rid of the pain from osteoarthritis or more inflammatory type of arthritis in your knee. And that is, I suppose, the most important thing to remember. So about 85% of people are satisfied with their knee replacement. So if you do need one, it can be a life-changing operation in terms of improving your pain and your function. But it's not a perfect operation, and it's different from hip replacement, I suppose, in that respect. Not that hip replacement is exactly perfect either, but about 15% of patients unfortunately don't like their knee replacement. And it's not because they run into some of the complications that we'll be talking about, and it's not because it's been done badly. It's because knee replacements, they don't turn back the clock, okay? They don't make your knee how it was 20 years ago. They will always be a knee replacement. And it's important to remember that when you're thinking about the decision about whether to have a knee replacement and really what you're expecting it to deliver for you. So it should give you a pain-free, stable knee that you can walk about on and get back to the activities that you want to get back to. But obviously that's different for everybody. And because knee replacements don't exactly restore how your knee moves, and because you've got a scar down the front of your knee, there are restrictions with what you can expect from them. And specifically things like kneeling and squatting. So if you've got a job or hobbies where you need to do a lot of kneeling or squatting like gardening, then it doesn't necessarily buy that back for you. And it's important to understand, I suppose, all of these things before you decide to go ahead with surgery. And it's also important to understand what to expect of your post-operative recovery. So whilst you're only in hospital for a few days, much like you would be for a hip replacement, or maybe you're going home on the same day, even depending on where you have it done, it does take a bit longer to recover from a knee replacement than it does from a hip. And I warn all of my patients that the first 6 to 8 weeks can really be, unfortunately, a little bit miserable in terms of pain and stiffness in your knee. But then you have a real improvement. You get most of the improvement by 6 months, but knee replacements continue to improve up to and sometimes beyond a year. So whilst it's an excellent operation, it isn't a quick fix.
Okay. Well, thanks for that, Chloe. I think that's a really useful and important overview to sort of provide a bit of context. And I think, unfortunately, it may not be the first time that some of you watching this have heard about, hip replacements being perhaps a little bit less challenging in some respects than the knee replacements can be. And why is that?
So that's a very good question. And if we knew that, then all knee replacements would hopefully be happy. So they're very different joints, your hip joint and your knee joint, and they move in different ways. And to put most knee replacements in, we have to take away one of the ligaments in the middle of your knee. And some people take away 2 of the ligaments in the middle of your knee, depending on what type of implant you're having. And that does affect how your knee replacement moves compared to how your knee moved to start off with. And whether it's that or some ongoing discomfort that you can have, or some stiffness, or some tenderness in your scar at the front of your knee, or a bit of numbness at the front of your knee, there's lots and lots of things that can all conspire together to make some people dissatisfied with their knee replacement. But if we knew exactly why people were dissatisfied, then we would hopefully have solved that by now. It used to be quoted that about 1 in 5 patients were not very happy with their knee replacement, and modern techniques and modern knee replacements have made that better, but we haven't solved it yet. So it's about probably 12 to 15% of people unfortunately still end up not liking their knee replacement.
Okay. Well, so we are moving in the right direction, and as you said, this is a common procedure. So if it wasn't for the pandemic and the impact that has had, roughly how many people would it be in the UK that have a knee replacement each year?
It's a very common operation. So, for example, in Edinburgh, we have a population that we serve of just under 1 million, and we do about 800 to 900 knee replacements a year. So about 70,000, I think, get done per year in the UK. So it's a very common operation that we're doing lots of normally.
Yeah. And for those who are getting ready for a total knee replacement now, or perhaps even in the early stages of recovery, as a rough ballpark, how long can one expect that knee replacement to last?
So modern knee replacements they're really very good. The implants, in terms of how they wear. So just as your own knee has worn out with time and needs replacing, knee replacements wear over time as well. And the plastic bearing that sits between the metal implants can wear over time, and that can make the whole implant loose. Now, that being said, more than 95% of knee replacements are fine still at 10 years. And when I say fine, I mean they haven't needed to be redone for any reason. And looking into the future, so even at 20 years, about 80% of them tend to be still functioning well and haven't needed to be redone for any reason. Now, it is important to remember at this point that is looking at all knee replacements that are done across the UK. And we keep an eye on them in something called the National Joint Registry. So we know when they're redone for some reason, but we also know that individuals' risks of needing it redoing are different. And there are lots of things that can make you more or less likely to need your knee replacement redoing in the future.
Yeah, absolutely. And of course, that's why it's so important that these conversations in every case are very much tailored to your unique situation, your considerations, medical history, and so on to feed your informed consent for your procedure. So here in this video, we'll be covering more sort of general topics and general things that are likely to be a consideration for everyone without going into too many sort of specific, unique details. So, well, when you are in clinic and you're talking about total knee replacement with one of your patients, how do you go about, beginning the conversation about the risks and complications, and how would you sort of take us through that in this sort of adapted form for the purposes of this video?
So I think the most important thing to talk about is the balance of risk and the symptoms that the patient is having. So I can look at the x-rays and I can see how bad someone's knee looks on the x-rays, but I don't, and I can ask them lots of questions, which I do, about their symptoms, but I don't know what it's like to live with their knee, and I don't know exactly what the restrictions are and the impact that it's having on their life and their quality of life, their ability to work, their ability to sleep overnight, all of these things. So obviously I ask them about all of those, and then we talk about the risks, which we'll go on to next. But I say it's all about the balance of how bad your knee is for you on a day-to-day basis, and is that bad enough to accept all of these risks of knee replacement? Because knee replacement obviously isn't the only treatment for osteoarthritis, and it's important that you have exhausted kind of non-operative measures, and that's things like having painkillers, doing physiotherapy, keeping the muscles around your knee strong, trying to stay fit and active, using a stick if you need it, modifying some of your activities to accommodate your knee. But obviously everyone has a limit, but people's limits are different. And once you've come to the end of your limit, then a knee replacement is a very good operation for getting you back, hopefully, to the things that you want to get back to.
Yeah, absolutely. And then I guess as the conversation goes into taking off, if you will, the different risks and complications to be aware of, that's where some people in particular can start to feel a bit uncertain and uncomfortable. But it really is an important part of that the informed consent process, knowing sort of some of the signs, some of the things to look out for. And it can also be really helpful for family and friends to have an understanding of as well, so that they can sort of start to understand the kind of journey that you are going to be on, or that you will be on, and then also what they can do to support, and how the sort of things that they can look out for as well.
Absolutely. I mean, the most important thing to remember really is that most people sail through this surgery without any complications at all. As long as you know to expect what to expect after your surgery, and what kind of length of recovery to expect, so that you can fit it into your life, and you can arrange to have help maybe from family and friends for the first while after your discharge from hospital, if you need it. But everything comes with risk, and everything comes with potential complications. It is important to bear in mind that those complications, fortunately, with knee replacements, don't happen very often. So I start normally by talking about the risk of infection, and the reason for that is because whilst the risk is very small, it's less than 1%, it's a very significant thing if it happens to you. So whilst the risk is low, if you are that 1 in 100 patients, then it is a big deal, and it has a big impact on your life. And the reason for that is, if you do get an infected joint replacement, it can mean multiple operations to try and get rid of the infection, and a long time on strong antibiotics, and that sometimes means a long time in hospital as well. So infection really is a big deal, and I think is the most serious of the more common complications, even though as I say, it affects fewer than 1 in 100 patients. That is, as we've talked already, that's kind of a population risk, and there are things that increase your individual risk as a patient. Things like if you have diabetes, you've got 1.5 times the risk. If you've got an increased BMI, you've got an increased risk because there's increased risk of wound complications and things like that. Unfortunately, if you've got an inflammatory type of arthritis like rheumatoid, that increases your risk of infection by 1.5 times as well. And if you've got a more complex problem and you don't just need a standard knee replacement, if you need a more complicated kind of knee replacement, that unfortunately increases your risk of infection as well. So your surgeon will discuss all of these kind of individual risk factors with you, but there's some of the things that can increase the risk of infection.
And of course, that those individual risk factors, that's exactly why, you know, your surgeon and their team will be aware of these personal risk factors, and that will form part of the plan, both before the operation, maybe even during and immediate recovery as well. So it's all about sort of knowing about these things for everyone in the team, and then the plan will sort of align itself to minimize all of those risks.
Absolutely, and it's all about informed consent. You have to know what you're letting yourself in for, and so that's why it's important to have a personalised discussion with your surgeon, who will know the rest of your past medical history and other things that are relevant.
Yeah. Okay. So, Chloe, what's the next next topic that you then move on to?
So I move from infection onto blood clots, so deep vein thrombosis and pulmonary embolism. And the reason for that is, again, they're rare things. So DVTs happen in fewer than 1% of patients, and pulmonary embolism, which is where you have a blood clot that normally starts in your leg and then can ping off, unfortunately, to your lungs and then be very serious as a result. The risk of that is lower still. So this is, again, affecting fewer than 1 in 100 patients. But if it happens to you, it can be potentially life-threatening, because unfortunately, a pulmonary embolism can be fatal.
Yeah.
Now, again, there's an element of a personalised approach. So wherever you have your knee replacement done, people will always give you what we call DVT prophylaxis, so some kind of medication to thin your blood to reduce your risk of blood clots. But whatever we give you, we can't make that risk zero. And there are other factors other than just having a knee replacement that affect your risk of blood clots, things like your BMI, so your body weight, your age, other past medical history. So particularly if you've got a personal history of having had blood clots before, or a family history of an immediate family member having had a blood clot, if you've got cancer of any type and you're receiving cancer treatment, or some other blood or clotting disorder, all of these things can affect your risk. And the higher risk you are, will determine what kind of medication you get given to reduce that risk. And that ranges from things like just aspirin to injections and some other tablet medication like apixaban or warfarin.
Absolutely, and I think for the same reason, most people who are having a total knee replacement will also be offered these DVT stockings or TED stockings or TED hoses. They go by a few different names and they come in a few different forms, but it's something that you're very likely to be recommended to wear, and you'll be, you may find that you'll need a bit of help from family or friends getting them on and off as well.
Put them on, absolutely. And whilst you're in hospital, you might get foot pumps as well, which are irritating but necessary. And actually, those mechanical things are as effective in the short term for reducing the risk of blood clots. But really, the most important thing is to get mobile again and get going.
Yeah, absolutely. Okay, well, so we've covered a few topics there. What would you move on to next in this?
This foray through complications. So we've done infection, we've done blood clots. They're the most serious ones, I suppose. And we talked a bit already about how long you can expect a knee replacement to last for. And we've also talked about the risk of dissatisfaction, which is probably the biggest risk in terms of the number of patients that it affects. There are other risks, unfortunately. Things like needing a blood transfusion, although the risk of that is much smaller now than it ever used to be, because we use something called tranexamic acid as part of your knee replacement to reduce that risk, and only about 3% of patients now end up needing a blood transfusion after a knee replacement. There is a risk of medical complications with any big operation, which includes a knee replacement, unfortunately. And that includes things like having a heart attack or a stroke after your surgery. And again, this is one of the things that is very much influenced by your general health and your past medical history, and that you would need to have a personalized discussion with. But all of these kind of bad medical complications that can happen lead to there being a risk of death, unfortunately, with joint replacement surgery, although that is very small. So that's about 2 in 1,000 patients. So it is a small risk, but obviously the worst possible. And you will probably find that if you do have other problems with your health that you take medications for, particularly if you've got problems with your heart or your breathing, then your surgeon may well arrange for you to be seen by an anaesthetist prior to your surgery to give you a real individualized risk of one of these really bad things happening. And that's important. That's an important thing to have, because as with all these things, you need to know what you're getting yourself into, because once we've done it, we can't undo it.
Yeah, absolutely. And I think you mentioned at the start as well about the limitations of a total knee replacement, and how it's not going to be as good as the original thing was once upon a time, perhaps, and that there may be limitations in terms of movement and the range of movement in the knee, how much straightening and how much bending there is. What sort of things do you cover in clinic around that topic?
So the biggest predictor of how much movement you're going to get after your knee replacement is how much movement you've got before your knee replacement. So if you've got, if your knee moves very well, then obviously we hope to retain that. If you've got a very stiff knee, it can be difficult to get you a full range of motion back. The aim really is to give you a knee that goes fully straight and will bend at least to 90 degrees. Obviously, we want to get more than that, but that's what you can reliably expect, especially if you've got a stiff knee. Now, if you've got more of a deformity going into your operation, so if your knee is stuck very bent and it won't go straight at all, or if you're very knock-kneed or very bow-legged, then your surgeon might decide not to try and fully correct that in order to give you a more straightforward knee replacement, because the complications of that are less than if they have to do a more complicated or a hinge type of knee replacement. So really the biggest predictor of your range of movement is unfortunately your preoperative range of movement. But some patients in the early postoperative period, so in the first few weeks, can really struggle to get their knee fully straight or to achieve 90 degrees of bend. And one of the things that I think is really important in the first few weeks after your knee replacement is your knee is sore and it's swollen, and it feels a lot more comfortable when you're lying in bed if you put a pillow underneath your knee, for example. And whilst it feels a lot more comfortable, that encourages your knee to not go straight. So if you do that routinely for the first few weeks after your knee replacement, it can actually be very difficult to overcome that and ever get your knee fully straight. But fortunately, the number of patients whose knee is so stiff that they need another operation, which is something called a manipulation under anaesthetic, where we try and get the bend back, that tends to be very low, and certainly in our department, it's only about 2%.
Okay, but yeah, that's certainly an important flag, and it's not the first time it's been brought up, and I'm sure it won't be the last in these joint school videos. Do not put a pillow behind the knee after.
Absolutely not.
As comfortable as it may be. Now, I think I guess we're sort of digging down into the area where there's, we're talking about things that could happen but that are really quite unlikely to happen. And there's You know, there's a few of these, and people, when you're doing your research around this, you may come across different things, and they may or may not always be relevant, and they may be really unlikely. But certain things that I guess it's still worth touching on, such as leg length discrepancy, or one leg ending up shorter or longer than the other.
Absolutely. So leg length discrepancies are more common after a hip replacement than they are after a knee replacement. However, if you have, as I've already mentioned, a bad deformity before you have your knee replacement, so if you've got if you're very bow-legged because you've really worn out the inside edge of your knee, then if that's completely corrected, then that does lengthen your leg, relatively speaking. And the same if you're very knock-kneed, so you can you can feel like your legs are longer, but it's really that the bone that is worn away and the cartilage that's worn away has been replaced. So it's not necessarily that you are longer, it's that you feel longer. And if that's the case with knee replacements, certainly it's very difficult to lengthen someone's leg by any dramatic amount. So if it was just a small amount, then that can normally be accommodated with a heel raise in your other shoe. Also, often people who have really bad arthritis and are kind of bow-legged as a result of it, it's often on both knees. And so if you get lengthened on one knee, then you'll probably get lengthened on the other knee when they correct that.
Okay. And I guess other topics that may perhaps be more relevant to hip replacement as well, but I think from the questions we see, there's often a lot of overlap, and often websites and books and things will cover the two together. But things such as the joint dislocation, and I guess another one as well would be sort of having a noisy joint, or sort of clicking and other funny sounds coming from the joint afterwards.
So it's very unusual for a knee to dislocate. It's a different type of joint. You can have knee dislocations, but it tends to be either if you were involved in some kind of high energy accident, like a car crash or something like that, or it is more of a risk if you're very large and you've got a very high body mass index. But knee dislocations, they're very rare.
Yeah.
In terms of having noise from your knee, if you've got arthritis in your knee, you're probably used to having some noise coming from your knee. And in fact, even if you haven't got arthritis in your knee, it's common to hear a bit of a grindy noise in your knee, particularly doing stairs and things like that. And that comes from the part of your knee joint at the front behind your kneecap. Now, sometimes after a knee replacement, when you have a knee replacement, not everybody resurfaces your kneecap. And so you can still hear a bit of that grinding occasionally. It doesn't mean that there's anything wrong with your knee replacement. So you should be reassured by that. But at present, knee replacements don't come in ceramic on ceramic, which is the hip replacements that can squeak. So squeaking doesn't tend to be an issue, though you might read that it is for a hip replacement.
And so I think we've done a good job here. Thanks to you, Ms. Scott, about going over a good segment, if you will, of the main risks and complications, and some of the more rare ones to cover as well. But something that I think is worth sort of going back to and covering a bit again, and because it is such a common question, is around pain control after knee replacement, and also the impact of a total knee replacement, or rather the likelihood of successfully treating pain, or perhaps vice versa, of still experiencing some pain for a period of time after a knee replacement.
So pain is the commonest reason for doing a knee replacement. Occasionally we do them because someone's knee is very wobbly because of their arthritis, but normally we're doing this operation for pain, okay? And if you think about the rates of satisfaction, so about 85% of people are satisfied with them, and that's by a year. So hopefully we're achieving an adequate amount of pain relief in 85% of people by 1 year. One of the main reasons for people being unhappy with their knee replacement, so being one of that 15%, is unfortunately some ongoing pain or discomfort. And often that can improve really quite late, and sometimes it can even take 2 years before someone's knee replacement is as good as it's going to be. So in terms of what normal would be recovering from a knee replacement, it is, it's a sore thing to have done, a knee replacement. And the first, 24, 48 hours, you will need and be offered strong painkillers, so strong opiate type painkillers. You will, more and more people are getting nerve blocks done at the time of their operation, again, to try and help with that, the post-operative pain in the first 24 hours. Most surgeons now put some local anesthetic and things in around the knee at the time of your operation, again, to try and help with that early post-operative pain. But despite that, with adequate painkillers and physiotherapy, you should be able to get up and bear as much weight through your knee replacement as you're comfortable. The bits are well fixed as soon as we've done the operation. They're safe for you to put as much weight on as you're comfortable doing. And normally people get home able to walk on sticks or crutches and do the stairs, manage to do stairs with those within a day or two. As I said already, the pain doesn't disappear immediately, as it can sometimes after a hip replacement. And the first six to 8 weeks, it gradually improves, but it can still be painful and stiff and swollen, and it feels warm because there's lots going on. But then it really does improve a lot. And as I said, you get most of the improvement by 6 months, although you do continue to get improvement up to and normally beyond a year.
Yeah, and of course the knee replacement in itself isn't sort of a lone silver bullet against pain and the impact of arthritis. There's many other things that together will combine in an effective solution. And your team will be going through that in terms of your pain management plan after surgery, but also really importantly, getting moving and keeping moving once you're back at home, and not putting the pillow behind the knee, and a number of other things that your surgeon and your physiotherapist and occupational therapist will be helping you to because that keeping moving and finding that balance between pain and movement will also play a really important role in not only managing pain, over the months of recovery, but also in getting and maintaining a good result from that operation.
Absolutely, and the fitter you are going into it, the faster your recovery will be. So if you can do some prehabilitation, so physiotherapy, keep your quads, the muscles at the front of your thigh strong in particular, all of these things, losing some weight, and trying to be as fit as you can going into surgery really does help you bounce back as quickly as possible.
Yeah, absolutely, and doing some upper arm exercise as well. It's often a forgotten thing when people start doing their squats and the good stuff. But actually, you may well be on crutches for a little while, and it can help if you've sort of waking up the arms a little bit before the operation too. But seek advice from your GP or from your surgeon or a physiotherapist about putting together a plan. That's always a good way to go about it. And so I think we've covered quite a few sort of general topics there, and then of course here we are in early 2021, and there's a whole new other topic that's sort of all pervasive and affecting all aspects of life, and very, very much so orthopedic surgery, as many of you watching this will know, who may have had surgery delayed and other issues with accessing post-op physiotherapy and other things like that. So of course, the impact of COVID on the risks and complications of knee replacement is probably a full interview or session of its own, and indeed it's something where there's still a lot to be learned, and it's an evolving space. But is this something that you're addressing currently? Like, what are you saying to patients who, you know, you're booking at the moment for surgery about this?
So I think for places to be doing joint replacements at the moment, for hospitals to be doing it, they need to have something called a green pathway, which is basically part of the hospital where all of the patients are screened before they're admitted to that ward, to make it as safe as possible, to reduce the risk of anybody catching COVID whilst they're in hospital. So, for example, most patients will be asked to self-isolate for a period of time before they come in for surgery. They'll then be tested. They'll have a COVID swab 48 hours before they come in, to make sure that everyone that's admitted has negative tests. And then places are testing staff and things like that. So they're really trying to minimize the risk of anybody coming into one of those green pathways with coronavirus, or anybody spreading it within that. So the green pathways tend to be, you know, you get a side room rather than being in a shared room with other patients. In terms of the risk to you of catching coronavirus when you come in for your knee replacement, it is difficult to know exactly what that is, because basically we haven't been doing very many joint replacements since the pandemic started. But what we do know is we were doing joint replacements when it started, and we know what the incidence of coronavirus was in the population then. So we know how much of it there was about in the first peak, when there was still joint replacements being done. And based on that data, we have estimated that the risk of you catching coronavirus because of coming in for your joint replacement is probably about 3 in 1,000.
Okay.
And the risk of dying from coronavirus related to coming in for your knee replacement is less than 1 in 1,000.
Okay.
So whilst people are absolutely right to be wary of the situation that we're in, you know, the absolute risk to you as an individual is very low. But if you do get coronavirus around your surgery, so if you either have caught it just before you have an operation, or if you get it in the first couple of weeks after an operation, then you're at more risk of getting kind of more of the serious consequences of coronavirus. So you absolutely want to avoid it and be careful for the first couple of weeks after your surgery, so that you're not mixing with other people and increasing your risk. But the absolute numbers are low, and the green pathways have been shown to be really safe and effective in terms of minimizing the spread of coronavirus amongst patients having joint replacements. So I think you can be fairly reassured that if your hospital has that set up and they are admitting you for a knee replacement during the pandemic, that they are doing everything that they can to minimize the risks, and that these pathways have been shown to be safe and effective.
Okay. Well, that's really quite reassuring, and I hope indeed that you know, most of this conversation is reassuring to the people watching. Is that very much is the intention, to highlight that, but also to highlight, you know, that again, and I've said it a couple of times, like COVID, the risk of COVID, as with other factors, is also another personal thing. And always ask your surgeon and other members of the team if you have a question, or if you think that someone in your family or someone has ended up getting a positive result at a certain point in time. And you know, things can get very complicated when we start to think about the timings of these things. And if you're thinking about it, worrying about it a little bit, always best to ask your team, and you'll get guidance on that. Good stuff. Well, I mean, this has been, I think we've done, you know, you've certainly captained this session admirably, and I think we've covered most of what is a bit of a tricky conversation to have at the best of times, and indeed maybe not anyone's favorite subject, but a very important one.
Absolutely. There's one thing that we haven't covered, that I haven't left until the end on purpose. But with any operation on any joint, there is a risk of nerve injury, and that can be used for lots of different things around the knee. So I think it's certainly worth covering. So to do a knee replacement, we have to make a cut at the front of your knee. So that's where your scar is. And unfortunately, there are really tiny little nerves in the skin at the front of your knee that we cut when we make that incision. And that means that it is very common after knee replacement to have an area of numbness at the front of your knee. And that can get in the way of things like kneeling. It is common, and unfortunately it's unavoidable. But what tends to happen is that you perceive it as being less of a problem, so it kind of gets better even though those nerves don't recover. So that's not really a nerve injury around the knee, but it is a very common not complication, I suppose, consequence of having a knee replacement. And it's something that if you don't get told about, you can worry about. So having an area of numbness at the front of your knee is very common. Fortunately, getting more severe nerve injuries around your knee is very rare. So sometimes if you have a bad knock-kneed deformity as part of your arthritis, then there is a nerve on the outside edge of your knee that can unfortunately get stretched or injured at the time of your knee replacement, and that can give you numbness on the top of your foot. But the risk of that is very small. It's less than 0.5%. And most reassuringly, the important nerve at the back of your knee and the artery that goes with it, the risk of injuring those at the time of having your knee replacement is almost theoretical. So it's one in about 10,000. Okay, so the risk of having a significant nerve injury at the time of your knee replacement, which would probably leave you worse off than not having your knee replacement, the risk of that is very small, and I think that's important to be aware of. But the risk of having numbness at the front of your knee is very common, unfortunately.
Yeah. And well, thank you for doubling back and getting that one. Is it here on my list, and I missed it as we went through. So thanks for that. That's a good one to cover. But we're pretty much at the bottom of the list, and we've talked about COVID. Is there anything else that you'd want to add for the purposes of this session?
I think I don't routinely speak to patients about it, but I know that it's on the list, and that's the risk of getting a fracture around your knee replacement. Now that is unusual, okay, and it's a lot less common than it is with hip replacements. And an example of that is, so as I've mentioned, in Edinburgh, we serve a population of about 900,000 patients. We do between 800 and 900 knee replacements a year. We see about 12 periprosthetic fractures around knee replacements. So that's fractures normally at the end of your thigh bone around your knee replacement. So they are fortunately rare, and they are more likely when you've had your knee replacement for a long time and you're maybe a lot older than you were when you had it put in initially. So they do tend to be more frail elderly patients than that get these fractures. So yes, they do happen, but it's not something to really worry about or certainly put you off having a knee replacement.
Yeah. That does remind me, actually, we did have an email the other week about someone who was asking about allergies. So in her case, whether it was significant that she has a nickel allergy, and whether that should guide the choice of implant and how that generally would impact having a total knee replacement.
That's a good question, and that's something that patients often ask, and the reason that they often ask it is because nickel allergies are so common. So depending on what you read, somewhere between 10% and half of patients will have a skin reaction to nickel. It's probably about a quarter of the population that will have some kind of skin reaction to nickel. but it's important to realize that that is very different from having a reaction to an implant that's implanted inside your body. And in fact, there is no evidence of it being a problem. So just because you have a skin reaction to, you know, nickel jewelry or something like that, it doesn't mean that you can't have standard knee replacement implants. So all joint replacements are normally made of some kind of alloy of metal. So they're not pure metals. They're a combination of metals, and most of them do have some nickel in them somewhere. And the reason for that is it makes them stronger so that they last longer. You can get implants that are, for want of a better word, hypoallergenic, that don't have nickel in them, but actually, you know, there's no evidence that it makes any kind of difference. And if 25% of the population do have a nickel allergy that would cause a problem, we should be seeing a big problem. You know, we do a lot of joint replacements. There should be a lot of them failing because of allergy, if that were the case, and it isn't.
Interesting. That's a very useful answer, and another reassuring one. So thank you for that. Super. Well, I think we can pretty much start drawing this to a close then. I think, I mean, we're there, absolutely, as with all these sessions, there is no way we're going to cover everything. And you know, if you recently read through your consent form, there may well be things down at the bottom that we haven't covered, and also, perhaps more importantly, there may well be personal factors that we've not been able to cover. But all in all, I think this has been a really useful overview of common risks and complications and some of the recovery milestones. So thank you very much, Ms. Scott. It's been really enjoyable. So thank you for that, and thank you for the time.
No problem. Thank you for asking.
And of course, thank you everyone for watching. Do keep sending in your suggestions for other topics to cover or questions, and we'll dig into them in an upcoming session. And until next time, everyone, stay safe out there and keep up the good work. Thank you. Bye-bye now.